Welcome back, everyone. Today I'll cover the 2020 ACR guideline for the management of gout, which put out a total of 42 recommendations, 16 of which are strong recommendations. How did ACR come up with such recommendations, one might ask? Well, 57 PICO questions were developed and followed by a systematic literature review, including network meta-analysis with ratings of the available evidence according to the GRADE methodology and patient input. A group consensus process was used to compose the final recommendations and also to grade their strength as strong or conditional. Prior to the 2020 guideline, there was the 2012 guideline, and the new 2020 guideline continues to reinforce many of the recommendations from the old 2012 guideline. But the big change for the 2020 guideline, I would say, is the focus on a treat-to-target approach for the management of gout. However, there is much more to this guideline than just the emphasis on the treat-to-target approach, so let me break it down for you. There's a total of 8 tables in the guideline full of recommendations for or against a specific treatment approach. Each recommendation is divided by the level of recommendation as well as various certainty of evidence for supporting such recommendation. Rather than going over each guideline in the order they're presented in the paper, which I think may be difficult to organize in your head for recall, I made a table like the following. So if you look at table X, you'll see that left and right columns are divided by whether a recommendation is for or against a certain treatment approach or method. Top and bottom rows are divided by whether a certain recommendation is strongly or conditionally recommended. So in quadrant 1, we have strong recommendations for a particular treatment. In quadrant 2, we have conditional recommendation for a certain treatment. Quadrant 3, we have strong recommendations against a certain treatment. And lastly, quadrant 4, we have conditional recommendation against a treatment. Got it? Okay, so let's get started with table 1. Table 1 is for indications for pharmacologic urate lowering therapy, which from now on, I'll just abbreviate to ULT. In quadrant 1, so these are strong recommendations for starting ULT. We have 3 indications. Number 1, having 1 or more subcutaneous tophi. Number 2, having radiographic damage of any modality that could be attributed to gout. And number 3, having frequent gout flares defined as twice or more every year. For number 1 and 3, so the tophi and having gout flares twice a year or more, the level of certainty of evidence is high. For the radiographic damage one, the indication, the certainty of evidence is moderate. In quadrant 2, we have moderate certainty of evidence for people who have previously experienced more than 1 flare, but infrequent flares, so less than twice a year. The example would be something like this. A patient comes in with a flare and you're getting history and you find out this patient had a gout flare 10 years ago and then another episode 5 years ago and then 3 years ago and finally presenting with another one. So they don't quite meet the criteria, the twice a year criteria, but they're still having prior history of gout. 3 other recommendations, conditional recommendations, with very low certainty of evidence. We have patients experiencing their first flare and CKD stage 3 or worse, serum urate level greater than 9 milligrams per deciliter, or urolithiasis. Under conditional recommendations against initiating pharmacologic treatment, we have 2 indications. So this is quadrant 4 now. Number 1, asymptomatic hyperuricemia defined as serum urate level greater than 6.8 milligrams per deciliter without prior gout flares or subcutaneous tophi. Number 2, initiating ULT is conditionally recommended against in patients with gout experiencing their very first flare with moderate certainty of evidence, with the exceptions of comorbid conditions such as CKD stage 3 or serum urate level that's elevated greater than 9, or people who have kidney stones. So let's just clarify something. Let's say you have two patients. They both have serum urate level of 10 milligrams per deciliter. But one patient is experiencing their first flare. Then you may consider starting ULT in this patient because his or her serum urate level is markedly elevated and they're more likely to experience gout progression. The second patient, let's say serum urate level is 10, but they're not experiencing gout flare right now and they don't have prior history of gout flares. They don't have subcutaneous tophi. The only reason why their serum urate level was checked was because it was checked during their physical from the PCP's office. So according to this guideline, you're not likely, or they're recommending against starting a pharmacologic ULT. But I'll say one thing this guideline underscores over and over is the need for shared decision making, as there may be patients who would prefer or benefit from ULT. So knowing the guideline with the level and certainty of evidence will help you while you participate and guide the patient in this shared decision making. Okay, moving on to Table 2. Table 2 gives recommendations for choice of initial ULT for patients with gout. Let's tackle the easy one first. There's the strong recommendations against pegloticase being used as first-line agent. Now, looking at the recommendations for various treatment options, and by the way, here in Table 2, all the certainty of evidence is moderate. So in Quadrant 1, we have 5 strong recommendations. Number 1, first-line agent for ULT should be allopurinol over all other ULTs, even for those with moderate to severe CKD, meaning stage 3 or worse. Number 2, xanthine oxidase inhibitors are preferred over probenecid for CKD stage 3 or worse. And this kind of feels like common sense, as decreased creatinine clearance is one of the contraindications for using probenecid. I can cover this more when I review gout meds. Number 3, for xanthine oxidase inhibitors like allopurinol or febuxostat, titration approach is recommended. So starting low, then titrating up to target is recommended over starting at a higher dose. So for allopurinol, you can start at under 100 milligrams per day or even lower in CKD. And for febuxostat, you can start lower than 40 milligrams per day. Number 4, giving concomitant anti-inflammatory prophylaxis treatment like colchicine, NSAIDs, prednisone over no prophylaxis is strongly recommended. Number 5, continuing this concomitant prophylaxis treatment for 3 to 6 months duration over less than 3 months with ongoing evaluation and continued PRN prophylaxis if the patient continues to experience gout flares is strongly recommended. Under conditional recommendations, we have recommendations for probenecid. So this one is pretty easy, as well as xanthine oxidase inhibitor. It is recommended that you start at a lower dose like 500 milligrams daily or twice a day with dose titration. The second conditional recommendation for ULT is so starting ULT during the flare. If ULT is indicated while a patient is experiencing a flare, this guideline says starting ULT during the gout flare over starting ULT after the gout flare has resolved is recommended. But I feel like this one needs some explanation. So this is not how I learned management of gout in training. When a patient flares, I was taught to treat the flare, especially if it was the first one. Remember, there was a conditional recommendation against starting ULT for first flare patients? But for the sake of argument, we'll say the patient is coming in with a flare, and this patient has all the comorbidities you can think of to make him or her needing ULT in the future. So you know this patient needs ULT. So do you start ULT now during the flare or once the flare has resolved? The reason for the timing of ULT initiation guideline was found based upon conceptual benefits, including the time efficiency offered by initiating treatment during concurrent flare visit rather than risking patient loss in follow-up. Also, there was input from the patient panel emphasizing that patients are likely to be highly motivated to take ULT due to the symptoms related to the current flare. Kind of makes sense, but what are the concerns of starting ULT during a flare? Well, there's potential worsening of a flare. Also, patient is already feeling miserable and overwhelmed, and adding ULT at the time of flare may lead to possibility of information overload and non-compliance potentially. Another practical issue I can see rising up is potential side effects that patient can experience with the new pills and not knowing which one is responsible for the side effect. Again, the guideline notes, as with all conditional recommendations, that there may be patient factors or preferences that would reasonably support the alternative of delaying ULT initiation until the flare has resolved. Okay, Table 3 is recommendations for all patients taking ULT, and this is where there's a big emphasis on treat-to-target approach. Two strong recommendations in Quadrant 1 are as follows. Number 1, treat to target, so high certainty of evidence for achieving and maintaining a serum urate level with target goal of less than 6 milligrams per deciliter over the use of no target. Number 2, also treat to target. They focus on the dose titration of ULT and subsequent dosing guided by serial serum urate level measurements over a fixed dose ULT strategy that is also strongly recommended. For your information, based on a randomized controlled trial from the UK, having treatment to target protocol demonstrated greater ULT adherence. Number 2, lower serum urate concentrations. Number 3, reduction in tophi. And number 4, a lower proportion of frequent gout flares at 24 months. How about conditional recommendations? So all patients taking ULT, number 1, augmented protocol by non-physician. So delivery of an augmented protocol of ULT dose management by non-physician providers to optimize the treat-to-target strategy that includes patient education, shared decision-making, and treat-to-target protocol is conditionally recommended for all patients receiving ULT. This is with moderate certainty of evidence, and the panel recognized that these resources may not be available in all healthcare settings, but the key here is to educate the patient and implement a treat-to-target protocol. Number 2, there's a very low certainty of evidence for continuing ULT indefinitely over stopping ULT. Personally, I think this is a hard pill to swallow for patients as who wants to be on medications forever, right? For patients in clinical remission taking ULT, meaning there's no flares for more than a year and there's no tophi, the voting panel consider ULT cessation or tapering. And if you decide to go this route, it'd be good to know that there was a single case series where ULT was withheld in patients' clinical remission with years of well-controlled serum urate level prior to cessation, and only 13%, so 27 patients out of 211 patients whose serum urate concentration remained below 7 while not receiving ULT, had no flares during a 5-year follow-up period. Also, patients with higher serum urate concentrations after withholding treatment had more frequent flares. The patient panel voiced concerns about a return or worsening of gout symptoms or tophi or joint damage with ULT cessation. So this one is where you'd really focus on shared decision making. Table 4 goes over recommendations for patients receiving specific ULT meds, such as allopurinol, febuxostat, or uricosurics. Let's discuss allopurinol first. All recommendations on allopurinol here have to do with potential adverse effects of allopurinol, which is AHS, or allopurinol hypersensitivity syndrome. So first recommendation is testing for the HLA-B5801 allele prior to starting allopurinol in certain populations such as Southeast Asian descent like Han Chinese, Korean type patients, and also African American patients. Asian population, we knew about for a while that they have to get the HLA-B5801 testing, but African American patients were added to the 2020 guideline. And in case you're curious about the statistics, Asian and African American patients taking allopurinol both have a threefold increased risk of AHS. And going along with that testing for HLA-B5801 allele, guideline conditionally recommends against HLA-B5801 testing in other ethnic or racial background. How about patients with a prior allergic reaction to allopurinol? There's actually a conditional recommendation for allopurinol desensitization for these patients with a prior allergic response to allopurinol who can't tolerate other PO-ULT agents. This is not what I'm personally recommending, by the way. I'm just telling you guys what's noted in the 2020 ACR guideline. But this is a very sensitive topic, in my opinion. If you have had an unfortunate experience of any type of drug reaction that caused the simplest form of rash or hives, you'll know it is just miserable, especially if it's pruritic or painful or both. But here we're talking about something that could be far more serious, like DRESS or Stevens-Johnson syndrome. So I would think long and hard before I opt for this option for patients with a known prior allergic reaction. And the level of certainty of evidence for both of these HLA-B5801 testing and desensitization are very low, by the way. Moving on to febuxostat. There's a conditional recommendations for switching febuxostat to an alternative PO-ULT if available and consistent with other recommendations in this guideline for patients with a history of CVD or a new CVD-related event. With the FDA black box warning for febuxostat, there was a FDA-mandated CARES trial of febuxostat versus allopurinol. Although there was no difference between the two arms in the primary composite CVD endpoint, febuxostat was associated with a higher risk of CVD-related death and all-cause mortality driven by CVD deaths compared with allopurinol. Interpretation of these results is complicated by a high dropout rate, with a majority of deaths occurring after ULT discontinuation, and the lack of an untreated control group means that the absolute CVD risk related to febuxostat is unknown. So after much discussion at the voting panel meeting, the guideline ends with emphasis on the importance of shared decision-making when considering febuxostat for patients at high risk for CVD. Lastly, we have uricosurics, and for uricosurics, there's two very low certainty of evidence recommendations against a couple of things. So first, it is against checking urine uric acid level prior to starting any uricosuric treatment. And number two, it is for patients taking uricosuric treatment, it recommends against alkalinizing urine. And the explanation for this is due to the challenges with 24-hour urine collection or nomogram-based testing, which can both be affected by diet and as such negates the utility of such testing. Next, Table 5 gives recommendations regarding when to consider switching to a new ULT strategy. So let's compare strong recommendations first. Both come down to when to initiate or when not to initiate pegloticase. First, when to recommend pegloticase. If you're a patient with gout on xanthine oxidase inhibitors, uricosurics, and other interventions have failed to achieve serum urate target and have continued frequent gout flares, or non-resolving sub-Q tophi, start pegloticase. But if you're a gout patient for whom xanthine oxidase inhibitors, uricosurics, and other interventions have failed to achieve serum urate target, but patient they have frequent gout flares, infrequent gout flares, so less than 2 flares per year, and no tophi, they strongly recommend against switching to pegloticase over continuing current ULT. So just to clarify, so even though treat to target is something they recommend in 2020 ACR guideline, this is not the only reason for starting pegloticase. Rather than just focusing on the serum urate level, at least when it comes down to the decision of when to initiate pegloticase, it has to do with frequency of gout flares and presence of non-resolving tophi. Next, conditional recommendation, we have patients with gout who are taking their first xanthine oxidase monotherapy at maximum tolerated dose or FDA indicated dose. So they're maxed out on the xanthine oxidase monotherapy, but they're still not at their serum urate target, or they have continued frequent gout flares, or they have sub-Q tophi that's just not getting better. Then there's conditional recommendation for switching their first xanthine oxidase inhibitor to an alternate xanthine oxidase inhibitor agent over adding a uricosuric agent. Next, in Table 6, we have how to manage gout flare, and we have a couple of high certainty of evidence strong recommendations. So these are number 1, first-line gout treatment being PO colchicine, NSAIDs, and steroids in any form, as opposed to using other agents such as IL-1 inhibitors or ACTH due to cost and tolerability issues. Number 2, for patients who may be NPO, intramuscular or IV or intraarticular glucocorticoid is still preferred over using IL-1 inhibitors or ACTH. For conditional recommendations for flare management, number 1, we have using an IL-1 inhibitor over no therapy. That is conditionally recommended for patients experiencing a gout flare with a moderate certainty of evidence. And number 2, using topical eyes as an adjuvant treatment over no adjuvant treatment is conditionally recommended for patients experiencing a gout flare. And this one is with low certainty of evidence. For colchicine specifically, the guideline notes that the FDA-approved dosing should be followed, so 1.2 milligrams immediately followed by 0.6 milligrams an hour later, with ongoing anti-inflammatory therapy until the flare resolves. And the voting panel did not further prioritize between the first-line agents, noting that the treatment selection should be driven by patient factors like comorbidities, access, and past experience. Table 7 discusses lifestyle management recommendations, and we have conditional recommendations for limiting alcohol intake, purine intake, high fructose corn syrup intake, and also recommending weight loss. But one thing that they note is being careful with patient blaming. Patients with gout frequently feel stigmatized when discussing gout with their providers. So this is something you want to do very gently with the patients. And also it might be helpful to tell your patients dietary modifications likely yield only small changes in serum urate concentration, although dietary factors may serve as triggers for flares. And recommendations against, we have vitamin C supplementation. This is kind of interesting. we learned, or in some review books for rheumatology, you will see that taking daily vitamin C may lead to modest reductions in serum urate levels. However, here the guideline notes that the voting panel reached a consensus that data on vitamin C were insufficient to support continued recommendation for its use in patients with gout. And they mentioned 2 small randomized controlled trials, but the sample size in these trials is so small, N of 29 and N of 40. So whether you recommend vitamin C's to your patients or not, it's up to you. But just know that according to 2020 gout guidelines, it's conditionally recommended against. Last but not least, we have Table 8, which discusses the management of concurrent medications. The medications noted here in Table 8 all have effects on serum urate level. And so hydrochlorothiazide and low-dose aspirin are known to increase or they decrease renal excretion of urate. So you have elevated serum urate level. And losartan and fenofibrate are known to have modest urate lowering effects. So conditional recommendations for, we have a couple of them. Number 1, switching hydrochlorothiazide to an alternate antihypertensive when feasible is conditionally recommended. Number 2, choosing losartan, preferentially as an antihypertensive agent when feasible, is conditionally recommended for patients with gout. In quadrant 4, we have number 1, stopping low-dose aspirin for patients taking this medication for appropriate indication is conditionally recommended against for patients with gout, regardless of disease activity. And number 2, adding or switching cholesterol-lowering agents to fenofibrate is conditionally recommended against for patients with gout, regardless of disease activity. So you may wonder, that's weird. Losartan and fenofibrate, they're both thought to lower their urate levels. So how come one is recommended for and the other is not? And switching, stopping, or adding a medication should only be considered when potential serum urate concentration benefits exceed the potential risks. So for something like low-dose aspirin on someone who had a history of heart attack, obviously you're not going to stop this medication just so you could lower a little bit of serum urate level, right? So I think this one is actually, I saw it on a couple of times. It's a common question that could show on the boards or in training that you do not want to stop low-dose aspirin. Okay guys, that wraps up today's talk regarding 2020 ACR guideline for management of gout. I hope today's talk was helpful. It was a bit longer than I had originally planned, but I think it still had a lot of good points that could be relevant in your clinical training. Next time, I'll be back with more topics on gout. I'll specifically cover gout meds that could be helpful not just in your clinical training, but also for your board studying, so stay tuned. And so until then, take care and good luck studying. Bye-bye.